Well, good afternoon and welcome to MedTech Crossroads. We're glad you're here. This is the 105th episode today, Friday, May 13th. I don't know if that means anything or not, but we're here today excited to be back into the clinician's perspective that we're going to be talking about in just a minute with our guest, Dr. Syed Ahsan. And we'll be continuing the series that we started last week with Dr. Niki Kennedy. But before that, we're going to give you a little bit of local news, and I'm going to be joined in just a moment by Dr. David Brophy, who's going to be telling us about the Midwest Growth Capital Symposium that's happening virtually next week. We're going to be part of that. There's the slide we've been showing you for the last few weeks. But we're going to switch over here to show you a custom presentation that Dr. Brophy is going to walk us through. David, it's good to have you with us.
Thank you. Thank you, Gene.
So tell us about this wonderful thing. This is the, what are we on here? Is this number 41?
42.
42,
actually.
the 42nd installation of what started as the Michigan Growth Capital Symposium, now the Midwest Growth Capital Symposium. Kind of amazing. Walk us through what's happening next week.
Well, next week, we continue with the symposium. It's a two-headed beast in a sense. It's interactive in that we gather up and review and select companies from the Midwest, Michigan and the Midwest, and have them prepared by a bunch of coaches and so on to be ready to present to investors, both local investors, Midwest investors, and investors from both coasts, who routinely every year look forward to this and have been good sports about doing it online the last couple of years. So the other part of it is educational and informational. And we have a lot of great speakers and panelists, and these things go on kind of in concert, and people move from hearing the talk to going and looking at deals.
And we got some pretty big names coming here. We've got your slides up here, and Steve can bring those up for us. Tell us some of these names.
Sure. Well, we have a kickoff from the university officials. We've got the Dean of the Business School, Francine LaFontaine, and the Vice President of Research, Rebecca Cunningham, both of them talking about what's going on with entrepreneurship and so on in the university. Our keynotes this year that lead off for us, Jan Garfinkel and Tim Peterson, who are the founders of ArborHive Ventures. Their moderator will be Ian Bund, who is indeed the Dean of Venture Capital in Michigan. We go then to what is perhaps the hottest sounding, if not actually the hottest, type of tech business in Michigan, which is termed mobility. And we have a panel of people who've been engaged in that field for the last few years, chaired very nicely by Jessica Robinson, who's co-founder of a new fund that is focused on mobility in Detroit. We go from there to preparing high potential young companies for venture capital funding. And we have one of the founders of Y Combinator, which is a famous institution on the West Coast and kind of a model for the types of things that various of us try to do with young companies around here, coaching them and getting them ready and so on. Then we bring together a couple of very successful growth company founders, Adam Lilling from Plus Capital in LA, and Chris Reisig from our own Renaissance Venture Capital, to talk about how to raise limited partner funding. And they'll be moderated by Dan Fader, who works at the University of Michigan Investment Office. Following that, we have an unusual, perhaps, company that came out of two people, came out of a large fund in San Francisco and started a fund in Columbus, Ohio. Chris Olson, who is co-founder of Drive Capital, will be our speaker, telling us why he moved, what was the attraction to the Midwest, and how's it all going. We then end up the first day with Kelly Sexton and Mike Saratakis, who jointly run what used to be called Tech Transfer, and which is now called University of Michigan Innovation Partnerships. So they're going to tell us about their activities and their track record and so on over the last few years. And they've done a dynamite job. On the second day, we start out with a group from the Michigan Economic Development Corporation. And that group, representing the state government here in Michigan, has been the leader, I would say, in the provision of various types of financing for young startup companies and startup funds. And so they're going to go through and tell us what they've been up to and what programs are on deck for them. Our second keynote speaker is one of our alums who's been very, very successful. Michael Stark runs what's known as a crossover venture fund in San Francisco, and he will be here to tell us what he thinks about the future of the public and private investment markets in the United States. Mike Saratakis will then return to our stage and lead a panel of individuals from various universities who are running funds similar to our Accelerate Blue Fund here at the University of Michigan. So we'll find out if we're leading the league or where we stand exactly with respect to that. Moving on from there, we have Gene Paranak, our local host here at the moment.
Wait, I heard that name before. Okay.
Yeah, well, he's very famous. He's moderator of a panel called the Healthcare System Startup Process, and we put a microscope on what goes on at Henry Ford Health System, it used to be called System, and the partnership with Michigan State and various other ways in which and channels in which healthcare startups come into existence. We then go to a very interesting thing, because now we see in this market around the country an awful lot of new funds. And these are new funds, in many cases, formed by people who have never formed a fund before. And so we have a company that serves these startups, these particular startups. And one of our alums, Kevin Crosby, is an executive there, and he's put together a panel to come and tell us about the characteristics of these first-time funds and these first-time founders. We've got a few of them in Michigan, and we got more of them that want to start. And so this will be very valuable insight, I think, for anybody who's interested in new funds. We then have Stephen Rapandalo, who has been for a number of years here now running MishBio. And this is a very important institute in our state that feeds deals, new technology out of our state into companies literally around the world, and causes that back and forth that is so fruitful and important in generating new companies and new jobs. And finally, we close the symposium with statement from Stuart Thornhill, who's the director of the Zell-Lurie Institute for Entrepreneurial Studies, and wrap it up. And
that's awesome, David. We appreciate your walking us through that. And I think we had one more thing in the last 30 seconds here that we wanted you to tell us about. You're offering a little sweetener here.
Oh, yeah, by all means. At the bottom of our slide here, please register if you're interested, and you get a $50 discount off your registration price. Let me make one more point just to prove how valuable this thing is. Yesterday, Goldman Sachs, it's one of our sponsors, announced the closing of an $80 million round for SkySpecs, one of the companies that went through our program a couple of years ago. So, it ain't California dreaming anymore. It's really happening here, and we're just trying to step on the gas and make it go faster.
That is awesome, David. Well, we are so proud of what you've done over the years with this program. Made it through through COVID, one more virtual time here, but you've had some great team coming behind you and making this all happen. MidwestGCS.com, friends of MGCS 22 for $50 off your registration fee. And David
right.
Brophy, thank you so much for that, for all you do. Thanks for being an advisor to MedTech Crossroads, and just for leading the community in getting together and talking about what everyone does.
There you go. Thanks, Gene, very much.
David Brophy, thanks again. Well, it's always good to see David on here. Just a couple more announcements, save the date. We have an echo here. The Michigan Medical Device Summit, Tuesday, September 20th, 2022, in Kalamazoo, Michigan. That run by MishBio. Looking forward to seeing you there. That has been a phenomenal event. So good to see that back in person. And coming up next, as a sort of a slot in the middle of our Clinicians Perspective series, it's the Women Who Innovate series. The first episode of that is going to be May 20th. That is a joint collaboration between Into Being, MedTech Crossroads, and the Michigan Economic Development Corporation. Thanks to Denise Graves, who has been putting that together with us. Our first week of that on the 20th is going to have Anna Schwendeman from the University of Michigan, Sonali Kurup from Ferris State University, and Mary Tibby from Spectrum Health. We're really looking forward to having them on May 20th. And like we said before, it's kind of, we're sort of breaking into the middle of the clinician's perspective, because last week, Dr. Kennedy, this week, Dr. Ahsan. 2 weeks from now, we're going to have another guest. And then on June 3rd, we actually moved it up to 4 weeks. We are going to have clinicians talking to us about their perspective. Because if you remember, we've talked so many times on the show about, do you have the customer perspective? Do you even know who you're building this for? And a lot of times the answer is no. But who better to hear from than from clinicians themselves? They know what they're experiencing. They know what their challenges are. They know what their day-to-day life is like. And so today, I am joined by our guest, Dr. Syed Ahsan.
Well,
welcome.
Thank you for having me and ArborHive being a part of this wonderful series. I actually had the chance to look at some of the podcasts that you have gone through, and this is amazing. You're doing amazing work, so congratulations to you on that, and thank you for having me on the show here.
I believe you are a person who knows a thing or two about wearing multiple hats, Dr. Ahsan. Your day job is a vascular medicine specialist. But before we talk about that, what your day-to-day life looks like, that's not the only thing you're involved in. Give us a picture of how you got to where you are today, what hats you wear, and then we'll go from there.
So my journey begins. So my father, he was an engineer, and my grandfather was a physician. So we lived in multiple countries over time. So my schooling was all from different places. But one of the most influential places I was at was called the American British Academy, which is a school in Muscat, Oman, which is a Middle Eastern country, where we get educated in both the American form of education and the British form of education. So, I went through the British system doing my O-levels and then A-levels from University of Cambridge. And then I had my med school in Pakistan. Like I said, it's been in all different places. And then for medical training, I came to U.S. and I've been coming to U.S. far before that, as both as a visitor and as an immigrant. But I started my training at Sinai in internal medicine, finished that, and then I felt like there was more to medicine than just practicing medicine. So I did research at Columbia University for almost a year with Dr. Tom Pickering, a very well-known in the world of hypertension, who came up with terms such as white coat hypertension, masked hypertension. A lot of people are aware of the white coat hypertension because it's so
get scared
popular.
Of doctors, kind
scared
of.
Of doctors, and your blood
Okay,
pressure kind of goes up. So I did research with him for about a year, and then I became assistant professor of medicine at University of Missouri, Columbia, where I had a chance not only to become a hospitalist, see the inpatient side, I also became the assistant program director for internal medicine residency. So I got involved with graduate medical education, interviewing 300 to 400 applicants per season.
Wow.
So you can imagine, if you did this for 3 to 5 years, you would have interviewed 1,500 people. So tons of experience there. I was also a part of the hypertension program there. So, got board certified in hypertension from a year of hypertension research with Tom Pickering. And the plan was to stay there, but things were to happen and I had to move. And I was interested in vascular and cardiology. And I I felt like I had more gravitational pull towards vascular, and I got trained at in vascular medicine at Oxnard, Louisiana. So that was another state I ended up in. And I got trained in both ultrasounds, venous procedures, vein disease, arterial disease, lymphatic disease. And through the whole process, I had garnered enough experience to learn how to start programs. And exactly at that same point happened to be that Henry Ford was expanding and looking for a vascular medicine specialist to actually start a vascular medicine section. So I got hired back in 10 years ago in Henry Ford Hospital to start their vascular medicine program. So then, of course, I became their vascular medicine program person, and I started from scratch. We had absolutely 0 patients in the beginning, and now we have a partner. We have lymphedema clinic, we have arterial disease clinic, or aortic clinic, we have a wound care clinic, which I oversee. I have the vein clinic, which I'm running with vascular surgery. The lymphedema is with plastic surgery. And then, of course, the run-of-the-mill vascular medicine clinic runs in between all there. And vascular ultrasounds, research, education. So we have research projects going on. And while we were doing all that, something was missing in action. So Dr. Kennedy and I and a few other people decided that we need to do more to do with our careers to make it more where we want to be. We want to add more to our feathers in our cap, and we started to become a part of the ArborHive, which was a platform of basically it's a connecting platform where we have individuals who have the knowledge and the expertise, but may not have the funding. People who have the funding may not have the expertise, and sometimes you have both, but you don't have perspective. And so we got involved with that a while ago, and basically Dr. Kennedy and I and two more of our colleagues came together to bring this to the forefront. While I was doing all this, I also felt like my educational piece was still missing in action, so I got enrolled in a program to become an Islamic scholar. So twice a week I study, twice a week I teach at a seminary locally here in Michigan. And if that was not enough, I sit on a local school board advising them about the activities of, who to hire, who not to hire with extensive hire experience. My connection with the local community comes into play. So after doing all that, I have some time left over, which I used to sleep.
That's where the sleeping comes in. I love it. And Dr. Ahsan and I are going to go out sometime, have lunch and talk theology. It's going to be great. It's a passion of both of ours. I think that's really cool, really fun. And of course, today you're here representing ArborHive. So everything we say today is a representation of ArborHive's way of thinking and everything else, not representing a healthcare system. But obviously, you've seen so many. You've been around the country, literally around the world, around the country. So many cool perspectives. Now, your day-to-day job, vascular medicine specialist. Dive into that for just a second, because people sort of know what cardiovascular is, they know what vascular is, or maybe they don't. So maybe define those for us and then show us how this is kind of both and kind of neither.
I always smile when I get that question. When I came to Michigan and wanted to start up the vascular medicine practice, one of the most common questions I got when I went to people to introduce the practice, what do you do? And that is one of the strangest questions that you can ask a doctor. Because normally when you go to your doctor, let's say your dermatologist, you don't ask, so what do you do, dermatologist? So it was a very strange question, but I understood where it was coming from, because people were not aware of the field of vascular medicine in this part of the world. In Europe, we are called angiologists, and we're fairly well known, and we are old, ancient. Here, we appear like as if we're the new kid on the block.
Oh, wow.
But what is it? It is a in-depth knowledge of vascular medicine or vascular disease from the cardiovascular perspective and the medical complementation to the vascular surgery practice. So think of this. You have a cardiologist and you have a cardiothoracic surgeon. The surgeon usually will not practice run-of-the-mill cardiology.
Okay.
And the cardiologist will not open your chest, put a new heart in.
Right.
So they're both complementing each other. At the same point, you have the urologist who does the surgeries and the kidney disease issues and tumors and so on and so forth. But the nephrologist takes care of the medicine aspect of kidney disease, such as electrolyte management, dialysis. So these are complementary services. So vascular medicine is the complementary service to vascular surgery and to cardiovascular medicine and the vascular piece of vascular medicine. So there's a lot of patients who don't have ownership. So imagine if somebody has a massive aortic dissection. So now you go to the hospital, you get the surgery done, but now who manages that? Because now it's not a surgical issue anymore. Or
surgery's not going to touch it because we're done with that part of it.
we're done with that.
Yeah.
Or they've had a dissection, but it is not at the surgical point as yet.
We're monitoring it.
So who is going to monitor it? Who is going to follow it? And then you come with problems such as lymphedema. The prevalence of lymphedema and the increase in the prevalence of lymphedema
This is a retention of water.
Retention of water, lymphatic damage through breast cancer, and any kind of prostate cancer or groin cancer. Forget about just that. Obesity is the leading cause of lymphedema. And we all know that is the biggest issue at this point. Adult individuals, or even in the pediatric population, are suffering from in the United States and the world, in the Western part. So it's a huge problem, but the question is, who is the doctor who takes care of this? Where do you go if you have a normal heart function, your normal renal function, and you have swollen limbs? The easy answer is the doctor throws a diuretic at you, some sort of a pill that makes you urinate more. And for a short time, it looks like it's the magical pill. But after 2-3 months, it stops working because the kidney kind of catches up to it.
It acclimates to it, basically.
Yeah, and it catches up to it. And it's like, okay, so now the water pills is not working. So you increase the water pill till the point the patient ends up in the hospital with dehydration because they have taken too much off, or electrolyte imbalance and kidney disease. So we don't want to do that. We want to treat the problem and not mask the problem. We want to treat the disease, not just the symptom.
This is a point that you made to me when we were chatting the other day, and I think it's a really profound one that needs to be heard more deeply. What are some examples of this place where I think you referred to sometimes our medicine is kind of, it's rudimentary sometimes. What are some examples of places where we're treating the symptoms and not the disease?
Well, like I said while we were talking this, I think, my opinion, that we are practicing an archaic form of medicine. Where medicine really needs to be is somewhere in the future. We're not there yet. We are far from it. Now, of course, the contemporary doctors who are practicing cutting-edge technology would say, well, what do you mean? We didn't have all this 10 years ago, 15 years ago, 20 years ago. And I'm going to say, absolutely, I agree. But are we there yet? And the answer is absolutely not. For example, do we treat diabetes or do we treat hyperglycemia? The answer is we treat hyperglycemia. Diabetes just continues, simmers, and prevails.
Wow.
Do we treat hypertension or do we treat high blood pressure? Because the disease, hypertension, is a lifelong problem. So there's a lot of things we do on a daily basis where the root cause remains unanswered, unaddressed. But the symptoms and symptomology, or the diseases that occur due to consequences of, they get treated. But the problem where it all began somehow gets lost in translation. So my objective usually is we should treat the disease if we can. And of course, treat the symptoms. We don't want patients to suffer, but how about focusing on the disease? Think about this, right? Today, to give somebody a vaccine, we take a metallic object, we sharpen it up, make sure a hole is in there, and we call it a needle, and we actually put it through the skin. And that sounds like, oh my God, why are we doing this? Is this the best form to administer this thing? At this point in time, the answer is definitely a yes. Wow. But is it the best form? I don't think so. Back in the day, you couldn't see what was going on in the chest. Now we have CT scans, MRIs, ultrasounds, where we can look into things without opening it up. Yep. Well, similarly, we need to advance more in this whole process so we can do things without getting into the process of cutting and injecting. So we are not there yet. We are getting there. There are a lot of phenomenal researchers who are themselves standing on the shoulders of giants that have come through and they are working on this technology that, why do we have to replace the liver? Can we just grow liver cells and do that? Similarly, with diabetes, they're working on cells that can produce insulin and can be injected into the body, and then that cell would grow and control the sugar. But we're doing all that, but we're not there yet. And that's what I mean, that we tend to treat the symptoms because we're not ready to treat the disease.
To treat the disease. I think it's profound. Does your role in between these two worlds of the vasculature and cardiology, I can understand if somebody's in a discipline that's kind of pushed up against a wall, like if what you do is cut on people, you're gonna look for people to cut on at some level. I'm not throwing surgeons under the bus, but
and you have quite a few on as guests, so you're definitely not doing that.
Right? No, of course not. But I think Niki said the same thing to me the other day.
Right.
Dr. Kennedy said the same thing. But it strikes me that you're in a unique role in between some worlds where you're not necessarily presuming that we should treat a disease this way or this way. You're able to sort of stand in between and say, what would actually be best here? Is that a fair assessment of the kind of role that you play?
Quite sometimes that is the role here. For example, when I started the lymphedema practice, and before it became the lymphedema clinic, we actually had to show that our processes of approach works. So you cannot start up a clinic and say, I'm going to treat this specific disease, but we really don't know how to. We'll just fix the symptom.
Right.
So that's not how a clinic can. Clinic has to offer help, both from the disease perspective and the treatment symptoms perspective. So we had started, and this whole process of treating such as edema or low extremity swelling is called the Dr. Ahsan's crazy diet. I didn't call it that. The patient started calling that. I just called it my diet, and then they called it Dr. Ahsan's diet. And because people perceived it to be so insane, they called it crazy Dr. Ahsan's diet. So it became Dr. Ahsan's crazy diet. But it is really not a diet. I tell a lot of my patients that had I been born in about, say, early 1900s, I would be out of a profession because the diseases I treat would not have existed back then.
We created these diseases.
We precipitated them with our lifestyle choices, yes.
Interesting.
For example, 1960s, 50s, smoking was common, accepted, and it became a part of socializing. I'm going out and having to have a smoke and a drink with my friend. That became a part of the socialization network. Doctors were smoking. They would smoke all the way to the OR before they would put the cigarette out and go and perform their surgeries. But later on, we understood maybe all is not well with this process. Mid-70s, early 80s, hospitals in England were performing 1 to 2 amputations a week because of smoking. And certainly, this thing started to surface like smoking is bad for us. And now, in majority of the corporations, places, smoking is not an acceptable behavior. And in some places, it is completely banned. But my point is, it took us 70 years to be there. Yeah. But what about processed foods? Right? What about processed foods? Think about this. 100 years ago, we did not have any methods of processing, refrigeration, microwave, canning, and all those aspects that we have were not available readily to us, not to the common population. We have started eating and drinking in a certain way which did not exist prior to the 100 years. And if I go back thousands of years from that time,
way, right, yeah.
like if I look at the Egyptian pharaonic diet, it would be no different to a 1910 American diet.
Wow.
It'll be still the same things, maybe a little bit of different of produce. Maybe it's more rice versus wheat. But the process is exactly the same. You grow it and you eat it. Natural, no processing involved. Many years ago, a food product was brought to litigation in England, and they said that they called it false advertising. So this company was calling themselves as selling potato chips of some sorts.
Okay.
And they said, well, this is false advertising. So the natural question was asked, what content or what percentage of this product is actually potato? And it turned out to be whopping 14%.
14%, and they were calling it potato chips.
So the question is, that is not the question. The question is, what is the 86%?
Right.
And it turns out a lot of chemicals. So my point is, a lot of people are not understanding that up to a certain age, your body is ready to take on these challenges and push back at it. But after a certain point, it kind of gives up. And then the fluid retention begins.
Wow.
For example,
And this is where the lymphedema is. This is
That's where
what you're treating here. This is
where
the
it comes
disease
from.
we're creating.
So my diet is towards taking all the processed foods out and processed drinks out. You know, do we really need to drink a lot of carbonated beverages? Because carbonated beverages are not water. People think they're drinking water, but in essence, they're not. Think of these carbonated beverages as acidic drinks. When they're brought into the gut, the alkali that is secreted by the pancreas reacts with this acid and creates three things: water, salt, and gas. We don't want water and salt. That was the primary reason we got the swelling to begin with.
Wow.
So we are in vivo creating salt and water.
And here you're not even talking about the sugar in the drink, you're talking about the carbonation.
I'm just talking about the carbonation. I'm talking about the zero sugar drinks, like which claim there's nothing in it except good taste. So and when I talk to my patients and tell them to stop doing these things, it comes as a shock to them. And they say, what am I going to eat? And I have to explain to them exactly how we were eating about 100 years ago, or thousands of years ago before that. So again, that helps resolve a lot of disease processes. For example, my patients who have come in hypertensive with obesity and diabetes on 3 or 4 medications, by just cleaning up their dietary cycle, they've been able to reduce their medications down to 1 or 2 from 4 and 5, or down to 0 from 1 and 2. Because guess what? The body is in harmony with itself and nature. But when we start throwing processed foods and chemicals at it, that harmony is thrown out of the window. So again, going back to your question, I do stand sometimes in the middle and wonder, how do I do this? How do we get to this point? I have patients who are coming in with small vessel disease. And just to explain, normally people have large vessel disease, like, you know, I'm going to lose my leg because the artery is blocked, and then they go in and they do bypasses or put a stent in. But what happens if you have normal circulation up to the ankles and your hand stops getting good circulation, or good ankle circulation all the way down to the wrists and the hand, or the ankle and the foot, and these things are, there's a small vessels that have stopped circulating blood. There's no contemporary treatment out there to treat this. And here you are, where a patient is sitting across you asking for help. So you are in a situation where you have to think out of the box, or as Niki says, throw the box out. Because now you are in a land which is really not being catered to. Nobody's studying these exceptional patients. And you have to come with treatment paradigms that are outside the box. And that's where the beauty of vascular medicine lies in, because it is such a niche base of knowledge that you have to study it, experience it, learn it, to acquire it, to disseminate it, to educate it. So that's why, you know, vascular medicine is such an enjoyable field, because when you sit in a room and you talk, you can see clearly that you're bringing a fresh perspective in the room. It's not
you're
been
seeing
there.
the problems, you're seeing potential solutions, and there's stuff you get to work with. It's not just a check this box, do this, we've always done it this way before.
Far from a knee-jerk reaction medicine, which is unfortunately where we are heading with a lot of the AI. I'm not saying anything bad about AI, but I'm just saying that many a times when you try to put a human problem in a certain funnel, it will not fit, or at least more people will not fit that model, because we are unique. Every individual with their diseases and their problems are unique. And I don't think in medicine ever we will come down to say one size fits all.
You know, it's fascinating, Dr. Ahsan, because I think, you know, someone could be listening, they could be saying, well, we're looking for the clinician's perspective, but we want to focus on the solution that we want to deliver. And what we're hearing from you is, hold on, the delivery of care, sure, sometimes there's something I do. I mean, you have all these vascular procedures that you can do, but you're turning the camera backwards and saying, okay, just forget about all these solutions for a second. Who is this patient? What are they going through? What is their body actually doing? And what could they be doing differently apart from these interventions?
Absolutely.
To bring health, which I think is it's profound and it's powerful, because if we, as solution innovators, wherever we are, don't go all the way back to that level with the question, we're going to miss some things along the way.
Absolutely.
So it's fascinating. Walk us then into this world of innovation, because you do work with devices, you do have procedures that you do. you've also been involved in so many things, and you've seen projects over the years, and of course we don't want to talk about specifics of who they are. But I know you've had a lot of stories of people coming and saying, oh, I've got this great idea, and you've maybe had to walk that back a little bit.
No, absolutely.
Give us some examples.
You know, we come across a lot of these, and you know, you're sitting and companies are pitching ideas to you, and you're sitting there and you're listening to them, and you're like, well, have I not seen this before? Or have I not heard this before? Or isn't that device that does exactly the same thing? So many a times, you know, what may appear as a fascinating idea to the person or the persons involved in this process, but if they would go out in the real world, they would find things that are similar to what they're trying to make. And sometimes it's not just about trying to make something that works. Sometimes it is about making something that works but has a purpose. Now, there are two different things here. For example, you know, I wrote a blog on this, jack of all trades and master of none. You build a device that does many things. It's a multi-purpose tool, especially in the world of medicine, which is so unique that, oh, I'm going to build a machine that's going to check blood pressure, that's going to check pulse ox, that's going to check finger stick blood sugar, and it's going to dispense pill. Oh, and it's also going to remind you to take your pills. And phenomenal, right? You got your entire doc in a box. It'll tell you exactly what needs to be done. Here's the problem. Not everybody needs all those things. Number two, I don't want to check my blood pressure all the time. I want to check my pill all the time. And the thing is, if I am one of those people who routinely forget to take my pill, not because I sometimes miss it, because I habitually am not used to taking a pill and I don't like it. So guess what? If I forget, I forget. How good is that pill box to me? And now, not only that it's a pill box, it's a multi-purpose tool. Now, it sounds like a phenomenal idea, but how many people are interested in this? How many hypertensives are diabetics? How many diabetics are hypertensives? How many of those have to check their pulse ox? Pulse ox have come to the forefront because of COVID.
Yes. Yep.
But remember, this is it's a millennial event. One in 100 years this happens. It's not going to last.
Yeah.
It may linger for a long time, but it's not going to change how people think for another 100 years. Spanish flu didn't.
Yep.
So my point is that you're going to build a multi-purpose tool, but for who and for what? Yes, it's phenomenal. It does so many things, but does it do anything well? And so that is one end of spectrum. The other end of spectrum is, oh, this tool that I just built, this stent, this device, is going to improve on the previous one. Everybody likes improvement. Quality needs to be better. Maybe a smaller introductory method or delivery tool.
Smaller, we're a little bit cheaper, or a little bit faster.
Right, cheaper would be a good idea.
Okay.
But the thing is, new products are never cheap. That is one of the things about new products. They usually are not cheap. Sometimes they can be. Most of the time they're not, because a lot of dollars have been spent in the R&D.
They have to amortize that to get that out. Yeah.
Exactly. So let's say I'm going to use this example. There's a stent that goes into the vein to stop blood from traveling to different locations, like a filter. And I come up with a new filter, and it does exactly the same thing as the other one, except for this one can be delivered at a lower size.
Okay.
Now, but the cost is going to be higher. So the question is, my previous stents were working just fine. I was using a bigger cut to get them in. I had no issues. It was cheaper. Patient's quality did not change. Outcome did not change. But now I'm putting something more expensive for a smaller 3 millimeter cut, smaller cut in the groin. The question is, will I really adopt this new technology? And we know physician behaviors are the most difficult thing to change. So the question is, are we really going to adopt this, even though it's more expensive, without the benefits of it having a newer edge to it? So developing a technology that pre-exists and improving it on it subtly, and not bringing on all the other positives, is a recipe for disaster. Because even though we are moving towards, making things smaller and more micro, but that has to come with an added advantage, a benefit. It's above and beyond what exists in the world today.
You know what's fascinating about that is you've sort of painted both of the ends of the spectrum, right? You've talked about I don't want necessarily the toolkit that has everything in it because it's going to be so inappropriate. It might cost more, but it might be harder to take around when this was easy to take around. On the flip side, you said a marginal improvement probably isn't going to justify the development cost. It's not going to justify getting into the group purchasing organizations that you have to go through for the hospitals or whatever it takes to get on that market. How could you qualify or quantify what is a good level to target? When we were thinking about this sort of generically, we could maybe take the stent that you mentioned and say the marginal improvement isn't enough, or maybe pick a different type of device that you work with on a daily basis. What's an improvement that isn't shooting for the moon? Maybe give us an example of what would be a moonshot, but you're not recommending it, versus a place where you said, if it could just do this, then I think we'd have a new device or a new market. Because it's a fascinating point. You've basically ruled out the two extremes.
Right.
And now we're sort of asking, in the middle, how do you find that?
I wish I had the right answer to that.
Sure.
I would be a millionaire. But nobody has the right answer to that, and that tells us why we have so many groups of people and organizations that are still in the world of innovation, because nobody has that answer. But what should be an answer to something like this? You know, one of the things we have to think about is solutions don't have to be complex. See, this is one of the Achilles heel of innovators, because they start thinking about very complex situations and how to decipher and deliver that complex situation. Sometimes solutions are simpler than they look. Problems are more prevalent than they look. For example, if I go to my clinic and I say, okay, how much of the Curlix is left behind? Oh, Dr. Ahsan, we only have 2 more. And I said, what happened to the rest? Well, we used them. And like, okay, we used them, but did we charge for them? How did we get reimbursed for this, you know, hundreds of dollars of product that we use for patient care, but did we really charge for them? Did we get reimbursed? And the answer is no. So what about developing something very simple that can actually look at the use and utility of daily equipments that we use, scissors, scalpels, tapes, and do an inventory of that on a daily basis, so we can actually look at what our running cost is. Many a times, if you look at a bill, majority of that is running cost of the clinic. And sometimes if they're overshooting it, they're charging too much to the patient. And if they're undershooting it, they're losing money on their end. Both of these are unfair to both parties. I think if we have a proper organizational tool that can actually monitor these things, individual to the patient, then we know what our per patient cost overhead is. And then probably we can deal, but there's no device like that. There's no equipment, there's no machine, there's no barcode, there's no software that does that for us. So sometimes the problems are prevalent, they are simple. For example, the big one on the wound care side is measuring the wound. Right now, there's
the size of the wound.
Yeah, the size of the wound. Right now, we're using a tape measure. But now we have all these camera technologies that can look at facial features and depth, and we can use them for screening and face technology. Why don't we just take the same software and apply it to the wound care, where we take a picture and it gives you the volume of the wound, 3-dimensional, depth, length, and width. Some of them have it. Most of the people don't. It's a novel. It is not a very complex thing to do.
Yeah.
The technology exists. All you have to do is take it up from there and deliver it in the wound care world. But it doesn't happen. And see, so these are the things that you see on your daily basis. You're like, why is not anybody coming up with this? It's simple, and it is specific. It is cheap.
Yep.
It's a software. You will use the same camera lens of any computer or phone device we have. It's not very complicated.
Yep.
It's an AI algorithm, but people don't use it and don't employ it. So the question is then, if it's so easy, why don't I do it? I wish I had the time and the crew to do so, because I am not really good with programming or things of that nature.
Yep.
So I would need somebody like Santosh, who we would be speaking to in a couple of weeks, that, hey buddy, can you get something up? And he may say, well, I'm not that kind of person. I'm this kind of person. Why don't we get, so you always I say this, and I wrote a blog on this also, that to develop anything simple or complex, you need to have a wider audience. you need to have people like yourself who has met individuals or many backgrounds and say, I met that person the other day and he said this about this innovation, or somebody like us who are on the forefront of the real world and say, yeah, that's not going to work because this is the problem.
This is how clinical practice actually works.
And then we need to know to target. Who do we target? People love to target hospitals because they think hospitals will always be around and they will have patients. I, on the other hand, would be the person to say, target the patients. There are more patients than hospitals, right? If I develop a product for a specific hospital setting, I am limiting myself to, say, 100 to 200 institutions across the state, or 300 or 400, whatever.
Sure, whatever the number, it's 3 digits.
But what if I'm going to target patients? Right off the bat, I'm in 7 digits. So having said that, when we are developing these softwares, these hardwares, these technologies, these apps, we need to know who we want to target. And the one thing I would definitely recommend all individuals, the goal should be to develop a product which is novel, easy, has agreed upon by different people that this is something that's going to work, and try to deliver it to the most number of people. This is your best way to have success. If we just target one entity, one aspect, one institution, the likelihood of success is not great. Unless the product itself is like, oh my God.
We suddenly hit the $1 million jackpot, but
if you do that, your chances of success is much higher. So the answer to your question is, we don't have the right answer to that question, but we do know what works and how we can get there. We have an idea of other products that have come out that have used this kind of 360 vantage point to look at it from different aspects and know how to deliver it and bring it to the right group of people. Back in 1992, there was a drug that came out in the market. It was supposed to be for an allergy. The drug barely got an FDA approval, but in around 1992, I think the law came out that the pharmaceutical agencies can target directly the consumers, i.e. the patients. And the ads started popping up. If you have this and this problem, let your doctor know. This drug will make you feel better. That year, that drug that barely got an FDA approval was one of the #1 selling drugs in the country.
Wow.
I'm not saying it is a bad drug or a good drug. My point is, if a doctor was prescribing, maybe it would not catch it on that quick. But since it went to the patients, the demand of it went up.
What's interesting about that is you're applying, if I understand correctly, you're applying the very same principle you started out today, applying to your own practice, where you're saying, let's look at the patients, let's see what they're actually going through, how can their life be made better before we even bring these interventions. And even here, and I'm not sure I've ever heard this perspective before, Dr. Ahsan, so I think it's really interesting and worth sort of putting a spotlight on. What you're saying, if I understand correctly, is when we go and think about how could we deliver a solution in this area, we might think to ourselves, oh, we're going to go into this clinic type. We're going to work with this clinician type. We do know that they're doing this thing, and so we think we can make their life better. Well, great, but I think you're encouraging us to say, no, if you really want to solve that type of clinical problem, you can't just say, well, these people always treat this, so therefore they're the right ones to give this kind of product to. You actually have to open your mind up and say, what are all the touch points where we could make a difference in this clinical condition, and then find the one that has the most people accessible to you in the easiest way.
Absolutely, absolutely. I think you said it very eloquently. That is what we are trying to get to, what I'm trying to get to. The thing is, we need to remember, especially on the healthcare side, no matter what we do and how we do it, the goal has to be the patient. We have to start thinking, we throw this term around a whole lot, and I'm pretty sure you must have heard it, patient-centered care.
Patient-centric.
Oh my God, patient-centered care. I provide patient-centered care. And when I was a young doctor, to me, that was a very fancy term. But I really did not know what it meant. I'm like, what do you mean by patient-centered? I am treating the patient.
Right.
Who am I treating? It is patient-centered because I'm treating the patient. And I realized as I grew older and as become more gray in my hair that I understood the difference. And so let's say a patient comes to me with leg swelling and bad veins. So I do an ultrasound, I find these veins are leaking, but they have swelling. But I'm looking at the swelling and I'm saying in my head, the amount of vein issues I am seeing in this patient does not match up with the amount of swelling I'm seeing in this patient. So suddenly, I have two issues. One, that the patient came in with, leg swelling. Two, a vein problem that I found. So now, shall I treat the vein problem, which will partially resolve that condition? Or shall I treat the patient problem, which should absolutely solve that problem? And that is the difference between patient-centered care and problem-centered care. If I was a problem-centered care guy, I would treat the veins and say, look, I found broken veins, I fixed them. You're not going to have any swelling from the vein perspective. All this other swelling you have, I don't know how to fix it. Go find somebody else.
Not my problem. Go ahead.
Go find some. That is a problem-centered care.
Wow.
A patient-centered care is you treat the swelling, you bring it down to the best abilities you can and say, okay, now the only thing left is the vein problem. Maybe if we treat the vein disease, the remaining swelling will be gone. And you do that and the swelling is completely gone, and that delivers a patient-centered care. Patient comes in with problem A gets solved. Not patient presents with problem A, I found issues B and C, I treat B and C, A remains exactly where it was, and the patient goes out of my clinic door. That is a very unhappy patient.
I did something. Don't blame me. It's not my fault.
Exactly. You fixed something, something that the patient didn't need fixing, but it's okay. You fixed it. So now I understand the difference. So when it comes to innovations, that should be the focus. We need to focus on the patients and their problems and try to tailor ourselves to that condition. Make ourselves aware of what happens on a daily basis. The famous term, be in their shoes. Honestly, innovators by far should be on the user end shoes. And if they're not, they need to find people who are on the user end shoes. And they need to speak with them and say, and this should not develop after the fact the whole product has been made and delivered and ready to be sold. Because at that time you put a lot of money and time and effort into it. It's too late. You want to do this when this idea is percolating. Hey buddy, look, I'm thinking of something like this. What do you think? You have been practicing in this area for 15 years. What is your take on this? Is this something that you think will benefit your patients? And then I can ask the question, what is your product? And of course, you want me to have a sense of privacy, so I don't disclose these things out there and then let anybody get initiative. So you need a trustworthy group, and that's where the NDA and everything else comes in. But my point is, you need to get that audience.
Well, it's so important because I think we've found in our world of device development at NTB, when we go to FDA, oftentimes questions will get thrown around or things, even before we're to a market question, and the agency won't actually know what the true clinical reality is. So all the way from product conception, all the way through a solution delivery, I think what you guys are doing at ArborHive is so cool, because this kind of a conversation, right, like of, hey, wait, let's think about it this way, this way, this way, from a clinical perspective. If you're a bunch of engineers sitting around, you're not going to be able to come up with what you're bringing up for these kinds of things, which I think is so cool about your offering. I just want to say to the audience, as we're coming up near the top of the hour here, if you have a question for Dr. Ahsan, feel free to ask it. You can raise your hand or you can put it in the chat. We did have a chat comment here from Kevin, a longtime listener of the show. Agree with Dr. Ahsan, there are 10K hospitals in North America, give or take, but there are 100 million households ripe for needed medical products. He adds, Kevin's opinion, I believe that private equity firms are going to learn this the hard way, but topic for another show. Thank you, Kevin. I appreciate that. That's great.
But it is true. I mean, it's not a secret. I don't consider myself to be, the smartest cookie around, but if I am thinking of this, and I'm not in the heat, in the battle, per se, every day, the individuals who are doing this will certainly think about it and say, what did I miss? What did I miss? Just like the pharmaceuticals, right? For years, they were told they cannot approach patients. They have to go to the hospitals and doctors and prescribers. And now the shackles are off.
Yes.
And medicines are being sold for the initial time whenever they have their the R&D's research work is being covered for millions of dollars. This was unimaginable at some point, maybe 30, 40 years ago.
And so now we've got a different type of market. We have to adapt to that. But it also gives us access to people that we wouldn't have had access to.
And the people have access to knowledge that they wouldn't have access to either.
Yeah. How does that play a role? And we got another comment there from Jeff. Great insights and perspectives from Dr. Ahsan. Well done. Thank you, Jeff, for that. The role of consumer knowledge in that. I remember when patient advocacy sort of was becoming a thing. I feel like that was maybe the 80s, 90s, and people were kind of going, hey, wait, I've thought about this. And for the first while there, it felt like there was kind of a sense of, well, that's nice, but no, you don't actually have a clue what's going on here. We have so much knowledge pouring out from every corner of the world, and some of it is still junk. Some of it is informative, and you do, I think, have, if people put their minds to it, they can become quite informed about a topic. How does that play in the role of care delivery? How do you feel about that? Like when somebody comes in and says, I've been studying this, what's the first thing that goes through your head? And how do you respond to that? And how does that affect this whole dynamic?
That's a double-edged sword.
Okay.
That's a very good question, but it's a double-edged sword. And I'm going to answer it this way. When a patient sits down across me and says, Dr. Ahsan, I read upon this, and I saw this, this, and this, and this, and I say, what was your search engine? And they say, Google. And then I'm thinking, oh my God. Yep. Or if the patient says, oh no, I looked this up, and I said, where did you see it? And he says, no, I went to PubMed and I saw articles on this. And I'm like, oh wow, this is great. Because if you are truly a patient's physician, you want your patient to be that educated, that knowledgeable. What am I looking for? I am looking for compliance. I will offer them something. A change in strategy of life, a diet, an exercise, a medication, a procedure, whatever I offer them, I want their buy-in. And that buy-in can only take place with the exchange of knowledge.
Yes.
The archaic medicine of trusting your doctors 100% and what they're saying is true and holy is not there anymore. A lot of the people and physicians are at fault for this also, have not been able to offer the care the patient needs, and hence that trust factors has over the years become a little bit less than what it was before. So if I have an educated patient come to my clinic and I tell them that this is what I'm going to do, and he says, oh yeah, I've read this. You're right, I didn't think about it this way, but I've read it. I am fascinated. He and I go a long way, or she and I go in a long way. But let's say they come and say, I read this on Google, and this is what Google says. And there's nothing wrong with Google. It's a great search engine. But imagine the stories people are putting out there. You know, imagine they're talking about the zebras. They're talking about the rare cases. And then those cases get applied to the mundane presentations, and here patients are going insane about, you know, do I have this? Do I have this? And then it gets a really tiring situation for people like myself who wants to educate the patient, but first I have to uneducate the patient from what they have learned, which is incorrect, and then re-educate them. So like I said, sometimes it's a blessing, sometimes it's a curse.
For a patient to know what they know and what they don't know, and to have some self-awareness of where they got that information, that could be a really good thing. But if they're coming in just saying, I heard this, so it must be true.
Yeah, so that is my take on that. That I love patients who come in with a degree of knowledge, and who are ready to reciprocate and hear and give their points of view. I've learned things from patients. I have learned things from patients who have come in and look, I found this article. Were you aware of this? And I've learned things are out there that are not supposed to be public knowledge because they're not the right thing. But this way you can have a good exchange. But when patients come in and they're convinced to what they have read online, and majority of it is coming from sources that are not medical, it gets very challenging. These small blog posts or where people have written their own life experiences where they had a cold and it turned out to be a brain tumor, or they had a leg swelling and it turned out to be a big malignancy of some sorts. Those cases happen, don't get me wrong, but they're not the 99% of the presentations. So education is phenomenal as long as it is coming from sources that can be vetted, such as PubMed, where research articles are published through peer-reviewed journals, up to date, which is continuously a medical Bible nowadays for doctors. So resources where you have information that's valid is great. Resources that are being loaded up because somebody wants to get their voice out and rare experience out there and using it to use it upon yourself, that knowledge, I think is the wrong thing to do.
You got to understand how it applies and where it fits into the body of knowledge. This is wonderful. Since we're at the top of the hour, I just want to mention we appreciate having you all with us today. Dr. Ahsan and I are going to continue the conversation here for a few minutes more, but it's 3 o'clock, and if it's the end of your time, we appreciate having you here on MedTech Crossroads. We're going to continue the discussion in coming weeks. But I do want to take a minute and go over, I think there was one really fascinating example that you gave me when we were chatting beforehand. And I don't know how much we can say about it, but the topic was geriatrics. You gave me an example of a domain where phenomenal work has been done, incredible solutions from a healthcare delivery perspective. It's now largely not there. No. Tell me about the geriatrics world, because I think there's for our audience, there's a very fascinating case study of, yes, you can solve the problem. Yes, the problem has been solved, but today we're not solving the problem.
Yeah. So many years ago, quite so many years ago, and I'm going to say more than 10 years ago, there was this thing out there that if you had a geriatrics floor or a section of the hospital dedicated to geriatric patients, where they would be admitted and be seen by geriatricians on a daily basis, and yes, they would have their specialists and consults come through, but their doctor who would take care of them would not be a regular hospitalist, but a geriatrics trained physician who has been trained in elderly care. They saw that the patients had less hospital stay, their outcomes were better in terms of rehab, orientation or disorientation went down, and overall they had better outcomes. But at the end of the day, the units came about, a lot of hospitals started adopting it, and then slowly it weathered out. It did not exist there anymore. And the question is, what happened? What happened was, when they had dedicated floors to the geriatricians and their patients, those floors were not admitting anybody else who came in. So if an 18-year-old came in with, say, a bad appendix, was not admitted to that floor. Sometimes the hospital's beds went unused. Sometimes the cost of bringing everybody in onto that floor, including the geriatrician, the pharmacist, the psychologist, the care, and the whole social work and everything else, the cost was pretty high when they were specifically tried for the geriatrician. So what happened was, while they were delivering all this phenomenal care, patient-centered, they were not able to deliver it at a cost that could be sustained. So non-sustainable financial care cannot be provided, even if it is better than the care they're getting nowadays. And that's one of the reasons why geriatrics or geriatrics units are not a common finding in most hospitals across the U.S.
Wow, it's amazing. It's been done well, but you can't sustain it.
It can't deliver it unless you have, some sort of funding or support from a philanthropic organization. Maybe you can, but then the question becomes of sustainability. Can you sustain that model? Can you have a geriatrics unit 24/7 for the following 15, 20 years? And if the answer is no, then why have it for 2 or 3 years when the money runs out and then everybody goes back to their old ways? And that's not the way to do business in medicine. We want to bring care that can be provided and improved upon as we move forward in time, and not just provide great care for this 2 years, 10 years, and then kind of go away.
Yeah, and it's the kind of thing where it takes hard work, right? I mean, when we were tracking COVID closely, I remember it was kind of sad. We had to look back to a time, I'm forgetting now how long it was, 10, 20 years ago, when the US government paid quite a bit of money to develop a ventilator. And they got the cost down to something like $3,000. And of course, early in COVID, everyone was going, where are we going to get ventilators? We got some folks on the show who developed out of U of M had developed a really cool ventilator splitter. So like in the worst case, you could split, and got it approved, cleared by FDA. There was a cleared designed device available at a $3,000 price point that got bought by some large company. There was no crisis. It was federally funded. And eventually it just dwindled and is no longer available, and wasn't available on the market when COVID hit, when it was needed. And it's that kind of a thing where sometimes the short term, what do we need here? You got to think about that sustainability aspect. How are we going to keep this there for the time that it is needed?
Especially with our population getting older and older. I mean, with COVID, we have seen the first time a decline in the life expectancy rate in the U.S. for the first time in COVID. But prior to that, we were always moving a few points ahead every year. Wow. So unfortunately, we saw that dip, but that dip is just a dip. It's not going to sustain, and hopefully we will beat this, and we'll move forward stronger than we came out of this, and we will see our population ages go up. But then, care centers as such will be needed more, and we have to come up with a better way to provide it.
It's amazing. Dr. Syed Ahsan, I'm going to give you the last word today. Thank you for being with us from ArborHive. You guys can do this kind of a conversation on any kind of a startup topic, any kind of a new product development. I mean, the breadth of talent that you guys have under the hood with yourself and with the others on the team. Just amazing. On your last word, as we think about innovation, we think about the clinician's perspective, we think about care delivery, where do you want to leave us today?
Well, first of all, thank you. And thank you for inviting us as a part of team to share our knowledge and concerns and experiences with the group and the wider audience. So thank you for everybody who has come together to see us and will be seeing us in future. My parting words when it comes to innovation is it's a great open field. Innovation is out there. We should run towards it, but we should try to remember basic rules of innovation that are not that complex. Try to keep it simple. Try to go for the lower hanging fruit rather than the higher hanging fruit that you can't get in touch with, but get the things that are easier. Sometimes the easier solutions are not there and they're very profitable. Try to get a bigger, wider audience. Get individuals involved who know a thing or two about this. I see many times innovation companies come with a very experienced clinician on their team, but their experience is not in that product. They have a clinician. There's a doctor with tremendous experience, and my God, that person could walk on water. But when it comes to the product that they're developing, the person lacks that knowledge in that specific setting. So I highly recommend to get groups like ArborHive or any other organization which has this level of expertise where people don't really have an interest in anything specific, but they're out there to share their knowledge. Get them on board earlier. Get them to sit down with you and talk to you. It's not that challenging. Get the patient's perspective. Make sure you remember the patient in the process of doing all of this. It's not about us coming up with a fancy device. At the end of the day, it is all about the people we help. And if we fail to do that, and we come up with a phenomenal product, we have still failed to deliver what we started off doing. So my parting words on this topic is very simple. Keep it simple, keep it realistic. The people who need it the most, you need to talk to them.
With that, Dr. Syed Ahsan, thank you so much for being with us today. It's always good to see you and good to see you here in person. And thank you for being here at MedTech Crossroads. And thank you for being here. Thank you for sticking around. I don't think we lost anybody at the top of the hour, so thank you for being here and for the comments today. We will look forward to seeing you next week, episode 106 next week. Thanks for being with us on MedTech Crossroads. Bye-bye.